If you're tired of confusing compensation plans, and if you liked our episodes that we did on compensation and break-even points, then this episode is for you. So we had questions come in, and I wanted to be able to answer those questions depending on different types of practices. OB specifically was the question that we had questions about. And so this episode is going to be talking about those compensation plans and really breaking down how you pay your people step by step. And that can apply for an OB practice, right, with global payments and so forth. It could apply to a podiatry practice that, say, has payer mix differences between different providers. So we definitely get it. Like, we hate hearing when compensation plans, create a conflict in the office or demotivate your team or fail to reward your top performers, right? So that's what this is all about. So can think of this as part 3 of the series on compensation. If you want to look back at part 1 and part 2, I think there are a couple episodes back, not that far. So today we're going to break down basically simple collections-based model that you can use to pay your providers. So obviously this episode came because we had some questions come up from one of our OB groups, and I realized I could probably provide a little bit more detail on how to make this work. Of course, if you do have questions, send them to info@natrevmd.com. That's natrevmd.com. And we're happy to try and help and answer those. All right, so we're going to kind of start from fresh, thinking that you didn't, listen to part 1 and part 2. So really, first things first, right? Really, really important that you're looking at your monthly metrics every single month. I talk about this all the time, so you can't hear me say it enough, but really, really important for you to understand revenue coming in, volume of patients coming in every month, and obviously that revenue breaking up by providers. So that's like your what you're generating piece. And then on the same side of it, you're going to be looking at your expenses every month as well, right? What are you spending every month, and how do these two numbers differ between revenue and expenses? Because at the end of the day, that is how you make a profit. And a profit is what drives your ability to keep doors open, pay your people better, career advancement, big fan of that, as well as obviously paying for yourself. So hopefully you'll like this discussion around compensation models, because I do feel like it can kind of be a little bit of a black box, or you're guessing, or even worse, you're paying somebody more than what they're bringing in. And that's going to fail to keep your practice in a safe financial piece. So I want you to also know that you're not alone in these questions and these concerns. This is a very, very common question I get from our practices. And the simple truth is most compensation models are difficult, right? And you do want a simple, fair, and transparent way to do this. And basically, the way we're going to go over today is something you can provide to your teammates. It is something that you can provide to your providers so that they understand, okay, this is what you're bringing in. This is your share of overhead. This is what is left. And this is the percent of that profit sharing that we are going to provide to you. And I think this is a really great way to incentivize your team. And you can always increase that percent over time with seniority in terms of the profit. But this is a really great way to incentivize your providers, your physicians. When I say provider, I really am meaning kind of physicians and mid-levels. I know people hate that word. It's just an easy way for me to lump both of those together. I certainly recognize in an office setting, physicians are physicians and mid-levels are mid-levels. So now that I got that out of the way, let's walk through this step by step. There is a blog on this topic. So if you go to natrevmd.com and you head over to resources to blog, you can check it out there. So we all know that for decades, practices have tried to make models work based on either patient visits or RVUs. And in the world of many different practices, that just doesn't work, right? OB is certainly one of them. It can help you, when I talked about part 1 and part 2 of the episodes, I talked about break-even points, right? So knowing your overhead, knowing how many patients you see, knowing your average receipt per patient helps you understand like how many patients you need to be seeing every day. That works really well in a traditional practice, but practices like OB, where you have global payments and so forth, it gets a little wonky in order to do that. So we're going to talk about a mechanism by which you can look at provider compensation, especially for those OBGYN practices, because again, we've got global packages, we've got C-sections, we've got surgeries, in-office procedures, I mean, ultrasounds, the list goes on and on. So a simple visit count, it is something to start, but it doesn't really get to the root of what all is going on within an OB practice. Obviously, you guys have recently heard my spiel on OB models and billing, and that's all changing in 2027. But honestly, the model that we're going to go over today could apply to any practice, OB or not, either before the billing changes or after, because it's all going to be based on overhead and the provider, what the provider is bringing in, cost of goods and services, and then expenses. So, which is obviously your overhead and cost of goods and services. So this is super simple and really important for you to sit down and get these numbers right. It is also something that I recommend you looking at every year, meaning if you set compensation, maybe meaning base salary, but your expenses change wildly, or you bring on new physicians, you'll want to recalculate this and then just reassess that the base salaries fit into the profit that individual has the capability of bringing in, and then also addressing any percentages in terms of how much percent of profit sharing. I'm a big fan of holding back some profit sharing until the end of the year to reward folks for staying with the practice for a long time. I think that this is just a really smart way to do it. Non-healthcare places do it. So I think that there's definitely value to saying, okay, well, if I'm going to give you 25 or 30% of the profit that you bring in, right, then we're going to take 5% of that and hold that until the end of the year and do a lump sum in December. Also protects revenue in case revenue drops and you need to cover expenses or something else unexpected happens in the practice financially. It's just a safeguard, I think. So rewards longevity with the company, but also safeguards from a financial perspective. Just my personal opinion. Again, all of this is an option or one mechanism to do it. There are many ways to do this. Obviously, I am not a financial expert. Please consult your lawyer and your financial team, your accountant, and so forth, in order to take these ideas and put them into place in your practice. All right, so first things first, you're obviously going to calculate your total annual practice economics. And so this is really a way for you to create a crystal clear picture of what's going on high level. So say we want to take a look at last 12 months rolling. Maybe in December, you can do through the end of November, right? Close the month and then look 12 months back. You could have done this for 2024, for a full calendar year. It's up to you. It gets hard to do this with a full, like you couldn't wait to do this in January, or I guess you could. You could wait to do this in January and look at a full 2025 and then set metrics for the rest of 2026. It just gets hard with close of year. So it's up to you. I really like the idea of just looking the past 12 months and close at the end of November, address salaries in December, and then have those go live in January. I just like fresh cuts. Okay, so say hypothetically you have a practice, they have total collections of $3.2 million annually. Cost of goods sold, again, an annual basis is say $820,000. So again, this is your direct costs like medical supplies, vaccines, IUDs, surgical materials, could be lab processing fees. And then you'll want to also have a line item for operating overhead. So say that's $940,000. So this is everything else that takes, keeps the lights on, right? So rent, staff salaries, EMR subscription, malpractice insurance, et cetera. So then you kind of have those three numbers, right? So we had $3.2 million is collections, $820,000 is cost of goods, and $940,000 as overhead. Again, if you're listening to this, just listen along. I do have a blog for this, and I think it's the exact same numbers. So step 2 is going to be calculating your full-time equivalents. So FTEs, this is a really important thing to do, especially if you have different individuals working different days of the week, meaning some are working 3 days a week, some are working 4. Maybe no one works 5 days a week, which is the example we're going to give today. So you'll want to know that because that allows you to spread say you have 6 humans, but 5 FTEs, because by the time that you calculate who is truly full-time and how many full-time equivalents you have, that's going to allow you to break up your overhead or your expenses by how much they are working, so that then it's, I think it's fair. Obviously, you could choose to do this by number of bodies, but if somebody's working 3 days a week, their overhead, in my opinion, is not the same as somebody who's working 4 days a week. But there are different ways to go about that. So again, no right or wrong answer here. This is just my view on how to do this. All right, so for our example, let's say a practice has 5 individuals, right? So they have 2 MDs, 2 certified nurse midwives, and 1 nurse practitioner. But not all of them are in the office 3 or even 4 days a week. So in this scenario, maybe their office doesn't have anybody who works 5 days a week. Especially in OB, that's common, right? You got surgeries, deliveries. So it's not like they're not working, it's just they're not in the clinic. So we're going to focus on clinic here. So maybe 4 days a week is the most anyone in the office works. So then you could use that to calculate the number of FTEs, where you set 4 days is 1 FTE. So then step 2, you're going to need to figure out your full-time equivalents based on the humans that are working. So in our example, 1 MD works 4 days a week. So she's 1 FTE. The other MD works 3 clinic days. So that would make him 0.75 of an FTE. One of the nurse midwives works 2 days a week. So she's a half FTE. The other nurse midwife works 3 days a week. So that's 0.75 again, FTE. And then the nurse practitioner works 4 days a week. So she again is at 1 full FTE. So you add all of this up and your actual practice has 4 full-time FTEs. So 4 FTEs. Again, we had 5 individuals, but when you calculate the number of days per week altogether, it's actually only 4 FTEs. So then you can calculate your final financials per FTE. So this is where it gets important, is you start dividing your total practice financials that we talked about previously by your total FTEs. And then we can then apply that to each human, right? If they're a half FTE or 0.75 of an FTE. So revenue per FTE is, so you take that 3.2 million divided by 4. And again, we're doing high level here. Then this will help you set a basis of what you want their base to be. And then you can then on a quarterly basis look at actual revenue brought in by that individual. And that will help you calculate the actual true bonus that you provide to them. So again, this is just for the purpose of trying to set their base salary or make sure that the salary that you have set is going to be covered by the potential. So again, that $3.2 million divided by 4 FTEs. So that's going to be $800,000 per FTE that is being brought in, right? So these are true numbers. This is what has actually happened. Now your overhead per FTE is $940,000 divided by 4.0. So that's 235. So then your 800 minus your 235, and you'll also want to subtract the COGS per FTE. So that would give you that profit per FTE. So then in our example, right, that $800,000 minus the $205,000 per FTE in cost of goods and services. So again, that, cost of goods and services we divided that by 4, the 940,000, we divided by that by 4. So everything's divided by 4. So that gives us the $800,000 in revenue, $205,000 in cost of goods and services, and $235,000 per FTE each, will then allow you to calculate $360,000 per FTE as your revenue benchmark, right? And again, this is historical. So the idea here is that as long as nothing's changing, that, goal should be able to be something that you can expect from 1 FTE. Now you may have 2 individuals who each work a half FTE. Them together should be able to bring in $360,000 per FTE. Now, this is the number that's really critical, right? It basically is the capacity that each full-time provider or mid-level or physician contributes to the practice. It's basically the pool of money that then is available to cover their salary. Because remember, your overhead and all that stuff shouldn't have included physician salaries. It shouldn't have included your nurse midwife salaries. All of that is going to come out of this pool that we just calculated, right? So $360,000 then becomes the important number for you to understand. Now you're going to want to do step 4, which is set your base salaries with that number in mind so that you can set a competitive base. Now, of course, you can bounce that revenue number per FTE, that 800,000, you can bounce that off of each position to see what they actually brought in historically over that last 12 months so that you can see, because you know a nurse midwife and a nurse practitioner is not going to bring in the same as an MD. You can either look at those historical, revenue targets that you had for 12 months, or alternatively, you can pull market data from sources like MGMA or AMGA. You'll probably want to do both so that you can establish this fair range for a base. So MDs may be making, in that $300,000 range, nurse midwives maybe 100, 120. But the key here is that you have to have these base salaries fit comfortably under that $360,000, especially if they're all physicians and they're all equivalent income potential. Obviously, if you have a wide range of income potential because you've got nurse midwives, mid-levels, et cetera, that's going to differ. But again, you'll just want to keep that 360,000 per FTE profit margin in mind and make sure that everybody's base is well below that. So say in this scenario, you decide that the MDs are going to be 300,000, the nurse midwives are going to be 125,000 base. All of those fit nicely into that $360,000. And again, then you could bounce those back against these individuals' 12-month ranges in terms of what they brought in. You'll just have to make sure that if they're a half FTE, that you recognize that their threshold is not going to be that 360, right? It's half that. So again, you'll want to make sure that you're calculating the base based on the percent of FTE that they are, right? So just keep that into mind. Now you're going to want to set annual thresholds. So this is simply the amount of collections a provider needs to generate to cover their own salary and, of course, their portion of the practice's overhead. And that threshold basically is your base salary plus your overhead allocation. So for our full-time MD, right, their threshold would be their $300,000 salary plus their full-time share of overhead, which is that $235,000. So they need to hit annually a $535,000 threshold before you're starting to bonus out anything. Now for a part-time individual, you'll just want to adjust that overhead proportionally, right? A half FTE nurse midwife would only cover half of that overhead. And anything an individual collects above their specific threshold is that excess collections, and that's what becomes bonus eligible. So again, that annual threshold is really that minimum amount of collections a provider would need to generate to break even for the practice. So in other words, it's the point where the provider has brought in enough revenue, right, to cover their salary and their share of the operating expenses. And then that's what you can set like anywhere from a 15 to 25% bonus, right? Because you're not trying to give them all of all of that profit sharing, right? The practice needs to keep some, right? That's the reserves. That's the ability to have hire in the future. That's also your share if you're doing the CEO work. Again, that's a business. Now, remember, cost of goods and services is not in that threshold formula because it was already baked into the other numbers that presented, and they're already tied to specific patient encounters. So don't double count that. Just want to make sure that that is understood. All right, now let's talk about step 6. So we're going to actually calculate bonuses using actual quarterly overhead. So this is an important step, right? So you've made your theoretical calculations. You've used last 12 months of revenue, overhead, and cost of goods and services. You've come up with the profit per FTE. You've then bounced off base salaries across MGMA, and that you making sure that it fits into that profit per FTE. you're making any adjustments if they're a half FTE or 0.75 of an FTE, et cetera. And then now you're going to want to, on a quarterly basis, I mean, you could try and do monthly if you feel confident that you can do this exercise every month and provide bonuses monthly. It just gets tough with pay period time cutoffs and the time that you close the month. So it just gets a little tricky. Again, not impossible, just need to make sure you do it timely. Obviously, you're going to want to actually calculate bonuses based on actual revenue and actual overhead that's going on, right? So if you're doing a quarter one, you're going to want to look at that individual's actual overhead, or the overhead of the practice, right? Divided by those FTEs, get that FTE equivalent of the overhead they have to cover. You're going to want to then take a look at the actual revenue that they brought in themselves. Again, subtract their revenue from, take their revenue and subtract their portion of the overhead they have to cover. Then you know what is left over. Then you can say, okay, now I'm going to give you 20% bonus on that amount, either at the end of the quarter, the end of the month, et cetera. And then maybe hold a portion of that back to pay at the end of December at Christmas time, or you pay it all. It depends on your contract, right? All of this stuff has to be spelled out very clearly in a contract, and it has to be something that everybody's on board with and that they understand. And then that's the amount you kind of check for. And again, that 15 to 25%, depending on the role, right? Higher percentages for your MDs, lower percentages oftentimes for some of the mid-levels that may be in your practice. Again, totally up to you. Depends, what kind of patients your mid-levels are seeing. Maybe they're seeing just the same as everybody else. We all know that their revenue sometimes can be lower depending on the fee schedules that are going on. So that is the way to bonus out and make sure that you are obviously thinking about how to do this fairly, I think is the most important thing, and that you're describing exactly your process and that you can share the numbers with your staff, because I think it's important to be transparent. Everybody knows that if you're the business owner, right, you're going to have a larger portion of the profits applied back to the business. But again, that's what allows you to keep the doors open. You're the one taking the risk, and also creating a reserve. So then that allows you to, hire a different individual or hire more individuals as your patient volume grows. So let's do an example. So say in quarter one, your full-time MD had a quarterly threshold of $135,000. Again, remember how we calculated that with the revenue, your fictitious last year's rounded up revenue divided by the FTEs and then divided by the quarter. So say this individual had a threshold of $135,000 that you had set aside that they needed to actually collect. So in this case, they collect $210,000. So the excess was $75,000. So then that's the portion. And maybe for this physician, they've been with you a long time, you give them a 35% bonus, then that quarterly bonus is $26,000. Clean, transparent, fair, directly tied to performance and the practice's actual financial state. Very important for you to be able to bonus people fairly. So the last step to this would be adding that optional end of year profit sharing. And of course, I think this is a good idea, but certainly, up to you guys. But it just kind of adds one more step for financial security for the practice, and as well as promoting longevity. So again, you can set aside that 10 or 15% of the practice's total net profit for the year and, provide that out. So maybe instead of that 35% bonus, you're giving them a 25%, and then a portion of that is held back to the end of the year. And maybe that allows you also to calculate profits based on a longer period of time, so you can ensure that you really were as profitable as you had intended, and always an extra reward for those top performers. I often find that folks are then wanting their metrics every month. They're like, well, how much did I bring in? What are my denials? What is my AR? Am I coding appropriate? It's like, there's just more skin in the game. So big fan of doing this type of model. In summary, this is a very practical, direct way for you to provide financial information to your team, align everybody, without it being super overwhelming. And again, you can use the part 1 and part 2 episodes to really think through in more traditional practices, not OB, how many patients you need to cover overhead and costs of goods and services and all of that stuff. But today we're just really talking about then how to apply that more specifically to compensation models. Obviously, first comes first, really make sure you know your numbers, pull your profit and loss statement from last year or last 12 months, right? It's December. Find those numbers, your total collections, your total operating overhead, and your total cost of goods and services, because you're going to need to know those. Then you're going to want to really understand your clinical capacity, right? This is all about how many true FTEs you have, not just humans, but FTEs. So calculate those FTEs to give you a realistic picture of per FTE, how much revenue are you having? How much overhead needs to be covered by each of those individuals? Obviously, schedule a meeting with your partners, your team, and really go over, what does your current compensation model look like? And how could that change as your revenue changes? Obviously, if you have questions, please reach out at info@natrevmd.com. We also have an eligibility tool. It is an in-depth document SOP that you can use to train your staff. It's the number one reason for denials that we see in practices. Typically, it's your front office staff. They're not recognizing that they need to do eligibility every time. They're not checking the payer portals. They're not confronting patients when it comes to eligibility errors and getting those new insurance cards. It is the number one thing that you are going to struggle to get paid on, because if you don't get those eligibility numbers updated, if you can't get the patient on the phone, you are going to struggle to collect on that. So if you are interested in that, check out the link below, and you can download the guide and use that as a training tool for your team. As always, it was great to chat with you guys this week. Let me know if you guys need anything else. Have a good one.